All right, so here the key concept is simple. The more the baby's head is flexed, the smaller the diameter is entering the pelvis, making vaginal delivery easier. So the more the head extends, the larger the diameter, making labor more difficult. And the more the head is flexed, the smaller the diameter of the baby's head entering the pelvis, making vaginal delivery easier. What is the attitude of the fetal head? Attitude means the relationship of the fetal head to the fetal body, specifically how much the neck is flexed or extended. Imagine the baby's neck. It can be the chin on chest with the well flexed head, right? Or it can be partially flexed, or it can be deflexed. And if you get a brow presentation, like if the eyebrows can be seen, that is basically fully extended. So as the head extends from the chest, when the chin is on the chest, this is fully flexed. And when you can see the brow, the face is fully extended. So as the head extends, different diameters enter the pelvis. Now, why are diameters important? Because the pelvis has limited space, and the diameter of the presenting head determines whether vaginal delivery is easier or difficult. A smaller diameter means easier labor, and a larger diameter means more difficult labor. So let's look at this well-flexed head, right? So a well-flexed head means a normal vertex presentation, right? So the normal vertex presentation with the head fully flexed, basically, this is the normal attitude of the baby, right? This is the chin on chest. The presenting diameter becomes the suboccipitobregmatic diameter, right? So the suboccipitobregmatic diameter, can you see why it's occipitobregmatic? Because it starts from the occiput and it goes up to the bregma, right? So the suboccipitobregmatic diameter is the smallest diameter. This is the fully flexed position. It's from below occiput to the anterior fontanelle, which is the bregma, right? So 9.5 centimeters is the smallest diameter of the baby's head. This is the smallest diameter that normally enters the pelvis. It gives you easy engagement, easy descent, and normal vaginal delivery. Whenever you hear vertex presentation, you think immediately about suboccipitobregmatic diameter, which is 9.5 centimeter. Now the chin lifts slightly, right? This is a less flexed head. This is commonly seen in occipito-posterior position. So whenever the baby is in occipito-posterior position, let me show it to you. So whenever the baby is in occipital posterior position, which by the way, you cannot see here. Let me show it to you. Okay, so can you see that this is occipital anterior, right? Occipital anterior means that the occiput is on the anterior side. So this is like the pubic symphysis and the occiput is on the anterior side. The occiput being on the anterior side means this one, right? So the occiput is on the anterior side. But here, the baby's face is turned anteriorly and the occiput is turned posteriorly. So this is occipito-posterior, right? So the occiput is basically posteriorly placed, right? So what happens in occipito-posterior position, the head isn't completely flexed. The diameter becomes suboccipitofrontal. So which one is suboccipitofrontal here? Can you see this suboccipitofrontal here? This is less well flexed and partially extended or deflexed. So basically it didn't flex. So suboccipitofrontal is like a relatively larger diameter. Suboccipitofrontal is around 10 centimeters, right? So it's from the suboccipit, below the occiput to the forehead, and the size is like 10 centimeters. So it's like a little below the occiput to the frontal side. So suboccipitofrontal diameter is 10 centimeter, right? It can still deliver vaginally, but labor is usually longer. Then we have a deflexed head. Deflexed head is occipitofrontal, right? Let me show you occipitofrontal here. This is occipitofrontal. The it's a fairly bigger diameter from the occiput to the frontal, right? So occiput to frontal is even larger than suboccipitofrontal. From occiput to front, you have around 11 centimeters. This is when the chin lifts even more. It's even a little, this occipitofrontal, can you see here? We saw the suboccipitofrontal, that was a little less, and occipitofrontal is a little more, 11.5 here, right? So this is the chin lifts even more. Now the forehead becomes the leading part. This is from the occipitofrontal is basically, can you see that it starts from the root of nose here, frontal region, all the way up to the occipit. This is 11 centimeter. And now we have another diameter. No, this diameter itself, the occipitofrontal is around 11 to 11.5 centimeter. And just a heads up about this one, the occipitofrontal diameter is when the head entering the pelvis is much larger. This is when it happens. And the result is that there's difficult engagement, there's slow descent, and there's longer labor. Now we have something known as the brow presentation. The brow presentation is mento-vertical, right? Mento-vertical. Now, mento-vertical is basically measured from the mentum to the highest point of the vertex. And this is the largest diameter. Can you see this occipitomental? This occipitomental diameter starts from the occipit up until the mental area. This is the mental foramen here, right? So the occipitomental diameter is the largest. This is when when you say that the baby has a brow presentation, right? It's measured from the chin, which is the mentum, up to the highest point of the vertex, and this is 13 centimeter. By the way, this is the largest presenting diameter of the baby's skull. Remember the pelvic inlet AP diameter? It was 11 centimeter. Even the transverse diameter is only 13.5 centimeter. So a 13 centimeter presenting diameter usually cannot negotiate the maternal pelvis. Therefore, brow presentation usually cannot deliver vaginally. You have to do a cesarean section for a brow presentation. Now, the largest, if an exam asks you the largest fetal head diameter, it's mento-vertical, right? This is basically occipitomental, right? This occipitomental one. This is the largest diameter. Okay, this is the brow presentation, and this is when you cannot deliver vaginally. It's usually impossible to deliver vaginally. Sometimes you have a face presentation. This is a face presentation. A face presentation is the face presentation. Now, something interesting happens in the face presentation. Something interesting happens here. The neck extends even further, right? So normally, what happens is the chin is lifted, chin is pressed completely to the chest. Now, the complete opposite thing happens here. The face is completely extending with the neck extending even further. So the chin is lifted completely. This becomes the face. The diameter that presents itself. Okay, so the face presentation is when the neck extends even further, the chin is lifted completely, and what happens is this also the presenting part is the face, right? So this also presents your submentobrygmatic diameter, which is again below the chin all the way up to the anterior fontanelle, and this is also, by the way, 9.5 centimeter. So students often get confused here. They ask, how can full extension be easier than brow presentation? The answer lies in the fact because when the neck is extended completely, the presenting diameter actually becomes smaller again, right? So the biggest diameter mento-vertical disappears. When you extend the neck fully, you get this small submentobrygmatic diameter again, right? Therefore, flexion is 9.5 centimeter and full extension is again 9.5 centimeter, right? And in the middle, you get that 10, 11.5, and 13, right? In the middle, you get this 10, 11.5, and 13, right? Okay. That is something about the skull diameters. Can face presentation deliver vaginally? So, can this face presentation deliver vaginally? Yes, but only if the chin mentum is anterior. Only when this mentum is anterior, it can deliver vaginally. Why? Because the chin rotates beneath the pubic symphysis, allowing the head to extend and deliver. If the chin is posterior, the neck cannot extend any further, right? If the chin is posterior, where is the neck going to extend into? The head becomes stuck. Therefore, cesarean section is usually required. So, a fully extended, a hyperextended neck face presentation will only deliver if the mentum is anteriorly placed, right? Okay. So that's a little bit about the attitude. If the attitude is well flexed, you have the suboccipitobrygmatic diameter, which is 9.5. It's the best diameter for vaginal delivery. And then we have the less well-flexed, partially extended or deflexed attitude, where there's occipitofrontal 11.5 centimeter diameter. And it's very difficult to deliver this one, right? But There's one that is between the well flexed and less well flexed. Like there's one in the middle of this, and that's suboccipitofrontal. The suboccipitofrontal, it's 10 centimeters, you can still deliver it, the one that's not written here. And then you have the brow presentation. The brow is very difficult, right? The brow is like 13 centimeter. The mentovertical diameter is 13 centimeter, or the occipitomental. So you can't deliver this baby vaginally. And the hyperextended phase presentation is again, you can only deliver it vaginally if the mentum is anteriorly present, right? Now something about occipitoposterior. Now, why does occipito-posterior labor become prolonged? Because in the occipito-posterior position, the head tends to be less flexed. Instead of presenting the ideal 9.5 centimeter suboccipitobrygmatic diameter, it often presents a larger diameter like suboccipitofrontal or occipitofrontal. A larger diameter engages less easily, it descends more slowly, and makes internal rotation more difficult. This is why occipito-posterior labors are often longer and have a higher chance of requiring instrumental delivery or cesarean section. So can you see what occipito-posterior is? That's my occiput and that's your posterior. So this is occipito-posterior, which usually presents with prolonged labor. So let's see a little bit here. So this is your occipito-posterior, right? Where the occiput is posteriorly placed. This is your occipito-posterior and this is occipito-anterior, right? And then we have left occipito-anterior, right occipito-anterior. You can see these babies clearly. This is left occipito-anterior, right? And this is right occipito-anterior. Then this is right occipito-transverse, and this is left occipito-transverse. Yes? And then we have left occipito-posterior and right occipito-posterior, right? Then occipito-posterior and occipito-anterior. So these are all the different positions that we can see the fetal positions in longitudinal lie and cephalic presentation, right? These are all the different examples of your fetal cephalic presentation. Okay, so let's get into the physiology of labor. The biggest question in obstetrics is every obstetrician would love to answer one question: what starts labor? The truth is, nobody knows the single trigger, right? Modern obstetrics accept that labor is multifactorial. Think of labor like lighting a bonfire. You don't start a fire with just a match. You need dry wood, oxygen, heat, fuel. Only when all the factors reach a threshold does the fire actually begin. Labor is actually the same. Many pathways become activated simultaneously. The five main players are basically the mother, the placenta, the fetus, some inflammatory mediators that we're going to see in a while, and some hormones. And every one contributes equally. No single thing is enough, right? These five players of the mother, placenta, fetus, inflammatory mediators, and hormones all combine to form the starting of labor. Now, maternal contribution goes on like that throughout pregnancy, the uterus is kept quiet. This is called uterine quiescence, right? Let me go and show you this. Okay. So throughout pregnancy, you have uterine quiescence happening, right? Now, the uterus is actually an organ designed not to contract for almost 40 weeks. Okay, so several substances keep it relaxed. What keeps it relaxed? Progesterone, nitric oxide, relaxin, and beta adrenergic stimulation. All of these keep the uterus in quiescence, in silent phase, right? Let me show you a better diagram of this here. You look at this. So all the inhibitors of uterine contractility are basically progesterone, prostacyclin, relaxin, nitric oxide, some corticotropin releasing hormone, human placental lactogen, all of them basically, and by the way, human placental lactogen also contributes in insulin resistance in the mother. And just remember that all of these basically lead to the uterus basically relaxing. Okay, so they relax with when term comes. Okay, when term comes, what happens is their relaxing influence decreases. Okay, humans do not have progesterone withdrawal. There is no progesterone withdrawal in humans. Unlike sheep, maternal progesterone levels remain high until delivery. So in sheep, the maternal progesterone levels remain high until delivery. But instead, in humans, we don't get this. In humans, we get functional progesterone withdrawal, right? What does that mean? The hormone is still present, but the uterus becomes less responsive to it. Think of it like insulin resistance. So there's this functional progesterone resistance, right? The cells stop responding. The uterus develops this kind of a progesterone resistance. So once progesterone loses control, contractions become easier, right? Okay, so the second player was the fetus itself, right? So the fetus also contributes. The fetus is not just a passenger, the fetus actively participates. As fetal organs mature, especially the lungs and adrenal glands, they release signals. These include cortisol, so you can see this corticotropin releasing hormone. The fetal lungs and renal glands release cortisol. The fetal cortisol increases near the term. Cortisol stimulates the placenta, and placenta produces more prostaglandins, and labor becomes more likely. So near the term, the fetus produces cortisol, right? Because the fetus has lungs and renal glands, so they release signals, and these include cortisol. And this basically stimulates the placenta, and the placenta produces more prostaglandins, and the labor becomes more likely. Now, why do fetal lungs matter? This is, by the way, a fascinating discovery. Near term, the fetal lungs release proteins such as surfactant associated proteins, and these activate inflammatory pathways. Think of this as baby saying, "My lungs are ready." The uterus responds time to deliver. So the fetal lungs also release some surfactant-associated proteins that activate inflammatory pathways, and this also uh, signals the uterus to tell the uterus that it's time to deliver. There's also some placental contribution. Now, what does the placenta do? The placenta becomes increasingly inflammatory. It starts producing large amounts of prostaglandins, right? This is your prostaglandin here, right? See, this is your uterotropins, the prostaglandins, and uterotronins, the prostaglandins, right? So what are basically uterotonins? Uterotonins are basically this class of medications that stimulate the uterus to contract or increase in tone, right? Prostaglandin and oxytocin both play a role in helping the uterus contract, right? They are routinely used in obstetrics to induce labor, manage the third phase of labor, and primarily to prevent or reduce life-threatening postpartum hemorrhage, right? Excessive bleeding after childbirth. So oxytocin and prostaglandins basically help you. What kind of drugs do we have? So the oxytocin like drugs like pitocin and syntocinon. These are, and then we have misoprostol, which is like a cytotec. This is a prostaglandin often used to induce labor, ripen the cervix, and prevent postpartum hemorrhage, right? So all these prostaglandins and oxytocin, basically uterotonins and tonics, basically make the uterus contract, right? Would you You can also see something known as involution here. Involution in labor refers to the process by which the uterus naturally shrinks, heals, and returns to its pre-pregnancy size and condition after childbirth, right? This crucial postpartum process takes about 6 weeks and involves strong uterine contractions to prevent bleeding and regenerate the uterine lining, right? The process of uterine involution basically goes like you have uterine contractions. Happens immediately following the delivery of the placenta. The uterus vigorously contracts to compress the blood vessels and stop excessive bleeding, which is postpartum hemorrhage. These contractions cause cramping known as after pains. And then you have cell shrinkage. Cell shrinkage is basically autolysis. The muscle cells of the uterus, which grew significantly during pregnancy, shrink back to their original size. This is autolysis. And then you have tissue shedding. The tissue shedding is basically lochia. The inner lining of the uterus sheds, resulting in postpartum vaginal discharge called lochia. And then you have size reduction. The uterus size shrinks basically dramatically. The uterus shrinks dramatically, dropping from about 1,000 grams immediately after birth to about 60 grams. So this is like from 2.2 lbs to 2 ounce, right? So it's like from 1,000 gram, you're going to 60 grams by 6 weeks, right? Factors that aid involution, basically breastfeeding. So breastfeeding nursing stimulates the release of oxytocin, right? And this oxytocin basically stimulates the oxytocin, which triggers uterine contraction and it speeds up the healing process. Then massaging the fundus, the top of the uterus, can help it stay firm, and also emptying the bladder. A full bladder can displace the uterus and prevent it from contracting efficiently. So it's very good to empty the bladder again and again, right? Okay, so where were we? We were talking about the physiology of labor, and we said that when labor was about to happen, we said that all the things that were basically stopping labor from happening was maintaining the uterus uh, go away, right? And the uterus stops responding to progesterone. This kind of progesterone resistance that develops, and the fetus adrenal glands and lungs basically secrete cortisol, and cortisol produces more stimulates the placenta to make more prostaglandins, and labor becomes more likely. And fetal lungs also secrete surfactant associated proteins that activate inflammatory pathways. And the uterus responds by saying time to deliver. And there's also some placental contribution. The placenta becomes increasingly inflammatory. It starts producing larger amounts of prostaglandins. And which prostaglandins are these? These are E2 and F2 alpha. So prostaglandin E2 and F2 alpha are both secreted. These are among the strongest stimulators of labor, right? So what is the inflammatory theory? This is an inflammatory theory. Something is called as an inflammatory theory. The inflammatory theory states that modern obstetrics increasingly view labor as a sterile inflammatory process, not bacteria. No bacteria are necessary. It's a sterile inflammatory process. Instead, immune cells are naturally accumulating. Right? Immune cells naturally accumulate. Examples include your macrophages, neutrophils, cytokines. They release interleukin 1, 6, 8, TNF alpha. These all increase prostaglandins, they enhance cervical ripening, they lead to contractions, and this explains why infections can trigger premature labor, right? Because in infections also you're creating all of these increase in immune cells. Infections exaggerate the same inflammatory pathways. Now, oxytocin is important. Oxytocin starts labor. Students actually think oxytocin starts labor, but by the way, it probably doesn't. Current evidence suggests that oxytocin becomes important after labor has already begun. Near term, the uterus develops many more oxytocin receptors. Approximately 100 to 200 times more receptors are expressed than early in pregnancy. Therefore, even normal maternal oxytocin levels become very effective. This explains why synthetic oxytocin works so well for induction of or augmentation of labor, right? I'll stop the video here before I go on to four essential events of labor in the next video.